You're all welcome back. The final session of the virtual International Cystinosis Conference is the expert panel, and I am delighted to welcome back all our speakers who will now be able to take your questions. So very shortly we'll start with the first question. So does the aminoglycoside allow the ribosome to simply overlook and therefore translate the gene into the proper
so
protein?
That is sort of the same question, but yes, that is what happens. It overlooks the minor mismatch that is created.
Thank you. For Herbie, do you expect any new side effects from the prodrug? You need to turn on your mic. Your mic is off, Herbie.
Okay, right now I was waiting for the host to unmute me. So we would not expect any additional side effects, and indeed we would expect to see far fewer side effects than is observed with cysteamine. However, because this is a new medicine, we are undertaking regulatory safety and toxicology studies, and only when they are complete will we absolutely have the data to confirm that. They're ongoing at the moment.
Thank you. The next question is for Stephanie. What are the risks of chemotherapy in patients with kidney transplant?
Okay. All right. So I couldn't unmute because the host didn't let me unmute. So sorry. So I didn't hear the question. And now I cannot hear. Okay, something's wrong.
Are there any risks of Are there any risks of chemotherapy to people with kidney transplants?
So normally no. For example, other kind of chemotherapy can be and are known to be toxic for the kidney and not busulfan. This said, you know, we were not sure. I mean, but there are a lot of people with kidney transplant who also got this busulfan chemotherapy, and it should not be affected. But you know, there are always risks. But so far, what we've seen is that the kidney function has been very stable during the whole kidney therapy process. It never dropped or never changed. So we are pretty confident on that.
Thank you. And we have another question for you. And I think the translators are just asking us both to speak a little slower. So it's from Dr. Manuel Jansen from Utrecht University. So do we know what, if any, is the effect of bone marrow transplant on tissues like muscle?
So I didn't show these slides because, you know, there were already too much to show. But we have done a study showing that the hematopoietic stem cells engraft into the tissue and differentiate in macrophages. Then, when they are there, they are able to transfer the lysosome carrying the cystinosin to the adjacent cells. So they can do it via exosome probably, but they also can do it via membrane protrusions called tunneling nanotubes. So we have shown the mechanism of action in other studies, but I didn't present that.
Thank you. And there were a lot of questions. People are very interested in this. They're asking, what treatments does Jordan now take?
So I'm not allowed to say that. But you know, I just, the only thing I can say is that he didn't change in any way. He doesn't take additional pills from what he was taking because it's autologous bone marrow transplant. So you don't need any immunosuppressant or you don't need any drugs because of a of chemotherapy. What he had to take when he was immunodeficient, he had to take some antibiotics, things like that, when he was very immunosuppressed. But now not anymore. So he doesn't take additional drugs. What he did is that he's off cysteamine and he take less supplements because he's losing less of the nutrients, that especially phosphate. But that's all I can say.
And the last question, were there any positive or negative surprises during the trial so far?
So, I mean, it was, ups and downs, for me, for all of us, it was, a learning process. We learned from Jordan and Barb, his mom, and as much as they learned from us. So I was, my team was seeing for the first time what was happening. But the thing that for me, the chemotherapy for the immunodeficiency, that actually a patient suffer the most of mucositis, it's pain in the mouth. And this lasts for a week to 10 days. So that was his worst side effect of the chemotherapy. So that was, but other than that, it has been, mostly expected event.
Thank you. We have some questions from Dr. Grimm from Ireland, and it asks that she had read somewhere that you don't recommend spinach. Is this true? And also, there are a couple of questions. Does indomethacin preserve kidney function?
Hi. So spinach is thought to be very healthy, and it's a vegetable, but it has a very large amount of oxalate. Foods with oxalate like spinach or rhubarb or black tea cause a lot of oxalate for the kidney to process, and that can plug up the kidney, causing stones and kidney damage. I have seen more than 4 or 5 children and teenagers where they had chronic kidney disease and they went on a spinach diet or spinach kick, and it led to rapid progression of their kidney failure. So if you have reduced kidney function, you should only eat spinach as a little bit of a salad, but not a big portion and not every day. Same with rhubarb, same with black tea. And vitamin C. Taking more than 1 gram of vitamin C a day is dangerous to the kidneys because vitamin C gets converted to oxalate. Okay. Oh, indomethacin. Indomethacin. So I'm not the expert here. Francesco Emma from Bambino Gesù in Rome has been getting data on indomethacin use across European cystinosis patients, and we're hoping that will be published. There's some evidence that people on indomethacin had improved or stabilized kidney function, but it's not published in a peer-reviewed journal yet. In patients that I look after, the infants and small children using indomethacin reduces the polyuria, reduces their thirst, and reduces the need for as much supplements. So I use it for their quality of life. But I don't have the answer to you about whether it protects the kidney in the long term yet. So we just have to bug Dr. Emma.
Okay, thank you. I should say that if any of our other speakers would like to come in during this session to just to do so, you can turn on your mic or raise your hand and we'll see you. There's I think a hand raising option.
Yes.
Somewhere. Paul.
Paul Goodyear. I was just going to say that Francesco and I have discussed the indomethacin business, and I think that his retrospective look at indomethacin was associated with good long-term outcome. But I know that Francesco's general policy is to use it for the little kids, and then by 6 years of age, switch over to an ACE. And I think that makes sense because it is somewhere around 5 or 6 years of age when you see the advent of glomerular disease and decline in GFR more rapidly, and proteinuria, albuminuria. And so I think it makes sense to, if you're going to use indomethacin, to switch over to ACEs somewhere in the middle of the first decade.
Thank you. Anybody else like to come in there? Any of the European doctors?
Well, maybe just a short comment there. The data which Paul Green was referring to really will be finalized. It's data on a large cohort of patients, and it really seems that the administration of endomethacin improves kidney function on long term. We don't really know the mechanism. Is it due to decreased urinary losses? What we actually think that endomethacin, which is anti-inflammatory drug, might contribute to arresting the disease progression in cystinosis, because several studies have shown that inflammation induced by cystinosin deficiency and accumulation of cystine crystals probably plays a very important role in the kidney disease progression. So endomethacin might be beneficial in this respect, but this is a hypothesis which needs to be proven. However, the drug seems to protect kidney function on long term. However, this effect is not very, very pronounced. And this data will be published. I hope it will be published this year, but we don't know yet.
Thank you.
Hope so.
And there's a question for Dr. Paul, it says, but I'm not sure which Dr. Paul, but you can choose. Do you think that 3D printed organs can replace organ donation in the future?
I'm waiting for my flying car. They said it was going to be available by 1990, and that hasn't happened yet. So honestly, I don't know. If I was going to place a bet, I would bet that the genetically engineered pigs as donors for kidney and heart will be available before 3D printed organs will be. But I would not bet very much money on that. We'll just have to wait and see. And I look at my other colleagues for their thoughts.
I'll make a comment on that one. This is Paul Goodyear. And so I think the problem with the printed kidney is that for all other things that we can print with computer, we know what the materials are that have to be deposited at a certain place. But in the kidney, what you'd have to do is to have a source of cells of at least a dozen different cell types, and probably 20 or something like that to make the kidney work well. And we don't have sources of every cell from the kidney, so we would not be able to deposit the right cell type in every spot. And the other thing that with all smallish efforts to generate smallish kidneys like organoids, and in the old days trying to conceive of transplanting little fetal kidneys, there's a huge problem with establishing a blood supply. Once anything gets big enough to be producing enough function to help us out, you need a pretty big blood flow going into the kidney. And that problem of hooking up the organ to rapidly, because as soon as it was big, it would have to be oxygenated, to hook it up to a blood supply and get oxygen from the get-go is difficult to imagine, and we have no solution for it.
Thank you. There's a question here. Can ibuprofen be used instead of endomethacin?
Well, maybe I will briefly, it was not studied actually, so because the initial studies used endomethacin, we don't really know, and I think endomethacin as a molecule, it's a non-steroidal anti-inflammatory drug, but it has some direct effects on the kidney in reducing sodium losses. So we don't know actually the answer to this question. I don't know. Maybe Paul Goodyear can comment.
Yeah, I would say no, because I've used endomethacin in a number of other renal diseases to reduce the fluid and electrolyte losses, like nephrogenic diabetes insipidus, Bartter syndrome, and in both of those instances, ibuprofen is simply not powerful enough to achieve the same effect, and it really has to be endomethacin.
We have some questions about fertility for Dr. Ahmed Rida. on the male fertility.
Yes. Yes.
So just give me a moment.
Mm-hmm.
In impaired renal function and fertility in cystinosis. That's from Southbury.
Yes, good question. Well, actually, we have noticed that there's a mirroring of the phenotype in kidney with the fertility status, but whether it is a causative or not, that's not very sure. We have to maybe study it more, investigate it more. But there is a mirroring between the phenotype in the kidney and the fertility status. So the answer is yes.
Okay. Another question. Have you successfully cryopreserved ejaculated sperm from a young cystinosis male yet?
Not personally, I'm not aware of that, but actually the technique is already there, so that's not a problem at all. That the technique is very old for cryopreservation. So once the sperm is there, it could be cryopreserved. But whether it's a special case than usual cases for other sperms, that we have to study, because we didn't study sperm in specific from cystinosis patient to be cryopreserved. Just to be sure that it's different from the others or the same, it can be used, how long it can be preserved, all these kind of measurements has to be studied on its own, but we didn't study it yet, unfortunately. But in principle, the principle is there, the hypothesis is there, the sperm can be preserved, and after preservation, it can be used later for fertilization in vitro. Yep.
And do you have any information on when the sperm production in these males starts to decrease? Is it sooner in cystinosis?
Well, when exactly, we have no idea. However, from the data we have, that it looks like, and from all the other previous reports as well, it looks like we have declining efficiency for the testis, or functionality of the testis, and for the gonadal function in general. So we aim at or hoping that the patients from younger age start thinking about this and start visiting the doctors and asking their doctors about this fertility opportunity that they can have in younger age before it's a bit late.
Thank you. Thank you. So we have another general question for the nephrologists. And levocarnitine, vitamin B complex, and any benefits?
Well, there is a pediatric neurologist at UCSD who has suggested that these might be helpful for patients. That's part of a mitochondrial cocktail, and the mitochondria are damaged in people with lysosomal disease. And so in people who have significant neurologic disease, she suggested it's worth trying. This is Doris Trauner, Trauner. I don't think it's ever been formally studied, but also many people who study inherited disease say that it sometimes can be useful. And I'd like to know what Paul Goodyear thinks.
Paul, your mic is off.
Yeah, I thought you turned it on. So I don't know, and I think that there's a sort of theoretic background to this, that the mitochondria are damaged, and so similar kinds of chemicals were used in experimental models to people in Virginia were studying this a bit, but I don't know in humans.
Thank you. So we have a question from Frick from the Netherlands for Christian, or Dr. Hohenfellner maybe on also. Can the Galileo treatment harm the transplanted kidney because of the vibrations?
Problem.
Not sure if Christian. Katharina Hohenfellner is on. You're welcome.
No, this shouldn't be a problem.
It'll be fine.
Yes.
Thank you. We have a question from Cindy for Christian or Justine. What can be done to help reduce muscle atrophy? Or maybe Katharina even would like to answer that one.
Well, I think, physical activity, if you start very early, as Christian showed already, I think this is very important. And what we see is if the patients start early and if they are on regular physical activity, they have normal muscle strength. We have now one patient and he's studying sports and he's extremely fit. So I think this is very promising. Is this answering the question?
Yes, thank you. Thank you. We have a long question here that I'll answer. I'll put forward. It'll be for one of the nephrologists as well. So it says, how will I get my child's bicarbonate level up past 15? It's been at this for a few years, and it's only briefly been at 20 for about 3 months. He's almost 8. He's on sodium bicarbonate, 650 mg pills. He takes 6 of these each dose, and he gets 3 doses a day. There is a fear that he may not be able to tolerate it from his nephrologist. Is there any other way to improve the bicarbonate?
Okay, I will try to answer. It's indeed so that some of the cystinosis patients have a...
Could I ask you to speak a tiny bit slower for the translators?
Okay, so it's indeed true that some cystinosis patients need very high doses of alkali therapy, such as bicarbonate or citrate. And when it's really impossible to control the level of bicarbonate, their indomethacin can help. So in these patients, I would advise to administer indomethacin because it also reduces bicarbonate losses and really can help to maintain acid advice. I don't know what other doctors can advise.
This is Paul. I agree with Elena about the indomethacin. I think that's the set. If it's a small kid, that's exactly the setting where indomethacin is quite useful. But the other thing is that it's hard to take a lot of sodium bicarbonate, and up to a certain point, after a certain point, kids just won't tolerate it. They throw up. It tastes salty. And so you can add, however, potassium citrate to the many other medicines that the kids take. And the citrate is converted into bicarbonate, basically. And so I usually wind up with a combination of the two electrolyte solutions, and they're better tolerated than either one alone. And the potassium citrate has the other advantage of supplying some potassium.
Thank you. Thank you. So we have a question. It's around the halitosis and the smell of the cysteamine, which is prevalent in both Cystagon and Procyspi. And still, after all these years, we haven't got anywhere with this, which is, we have this great treatment in many ways, and all of these huge problems that have a problem that are a problem for patients. So some patients take vitamin B2 riboflavin to combat the smell. Is there any evidence that this is effective? And also, would you recommend anything to deal with this side effect? And it is an area that certainly patients are very interested in, and there would certainly be a lot of interest in some research in this. So if anyone would like to take that one.
Okay, I'll answer this question because Martina Bezau in our group studied halitosis. As it was explained, halitosis is due to the metabolites of cysteamine, and it's a very unfortunate side effect, and it's really proportional to the dose of cysteamine that patients are taking. Patients are taking different substances like Oropur or Breathasure or vitamin B or some other things to mitigate the smell. And some people say that it helps, or it doesn't help in all of them. And actually, there is virtually nothing we can do about it, because the substance which causes halitosis is very inert, so you cannot really bind it or you cannot really reverse it. So that's a big problem. So the only thing we can do is somehow to modify the drug, allowing us to give less cysteamine. And in this regard, I am very much enthusiastic about the prodrug, which Herbert described, because this would allow to give the lower dose of cysteamine, which would be equally efficacious, but will probably provoke much less side effects such as halitosis. And this would be a good solution. Of course, other novel therapies which were proposed by Paul Goudier or Stephanie Cherki, which are not allowing cysteamine, obviously they will not produce the side effects, but I think for the very nearest future, I think the prodrug might offer the solution.
If I may come in as well there, I agree with Elena. One of the potential advantages of prodrug therapy is that the prodrug can be absorbed intact into the cell from the bloodstream, and so the release of the cysteamine from the prodrug can be intracellular, and that traps the cysteamine within the cell. That's one of the potential advantages over cystagon and procysbi, which release the cysteamine into the gut and then can cause odor problems and nausea and vomiting and so on.
Yes, certainly in the CF10, both the preclinical toxicology and...
Herbie, can you move closer to your mic, please, for the translators?
Sorry. In both the toxicology with CF10 and the phase 1 trial, we will be measuring the methane thiol and the dimethyl sulfide levels. And I see that as a really early go, no go decision point on the future of the drug, because as Elena has said, the much lower circulating cysteamine levels that we see after CF10 should mean much less metabolism to volatile thiols.
Thank you. So another question, and I suppose I will just reiterate here today that we're recording and that nothing confidential should be shared. So we're recording here today. So we have a question. What are any of the doctor's view on the use of PPI and procysbi together?
So the PPIs stop the production of acid in the stomach. And some people must take them because they have severe gastroesophageal reflux. If that's the case and you don't have acid in the stomach, the procysbi granules will dissolve too early. See, they are designed so that they stay intact in acid and stay intact until the procysbi passes into the intestine. So it depends on having stomach acid. If you don't have stomach acid because you're on PPI, the procysbi might all release in the stomach and give you basically just very expensive cystagon. If you have to take PPIs, you should take your procysbi with a source of acid like lemon juice or a black soda like Coke or Sprite to give some acid to be in the stomach to keep those granules intact. It's definitely an issue which a lot of people experience.
I think we had a question about that earlier on that just came into our email, and an issue that there was an understanding that the granules wouldn't release in the stomach because the polymer surrounding them wouldn't allow them to release in the stomach. Because I understand that some families are having problems where the child, after 2 hours after the dose, was vomiting up the beads.
Mm-hmm. So the polymers only know they're in the stomach because there's acid, and that is why the polymer keeps the pills intact. If there's no acid, they will release. Now, some children and some adults may have delayed gastric emptying from illness or from chronic illness or from end-stage renal disease, and there's a variation of how much time it takes to empty the stomach and for food to move through. So if you're seeing some beads when the child vomits 2 or 3 hours after the dose, it could be that your child's gastric emptying is a bit slow, and that's something to discuss with your care team.
I agree, Paul, and it's equally true that proton pump inhibitors can reduce gastric emptying time anyway, so that's a double problem almost. But you're absolutely right. The release of the active drug from ProCysB is pH controlled, and if you artificially raise the pH of the stomach with a proton pump inhibitor such as omeprazole, then there's the potential for the drug to release too early.
Okay. I would just like to add the comment which was done this morning by my colleague Marlies Cornelissen from the Netherlands. I think it's an important one, is that the capsules of ProCysB can be opened and the granules can be given through the tube in the patients, in the small patients who cannot swallow the capsules, and it doesn't really impact their delayed release of system in these patients. It's nothing to do with PPIs, but I think it's an important comment to do, that also this drug can be given to young patients.
Thank you. And so we have a question that's a little bit long, and it's from Tony, and he has said, I have recently been told I no longer present with the cystinosis gene. I was told to stop Cystagon about 2 years ago, and I was wondering if I could be possibly wrongly diagnosed. Or is it possible for the body to get rid of this disease? I am now 38 and was diagnosed at around 3. I still present with Fanconi syndrome, I believe.
I think who from the doctors would like to address this issue? Paul Gozier?
Well, I think this gets into your personal clinical information, and I don't think it's that we should be answering that, because I'd have to ask you questions about exactly what the mutation or lack of mutations was, what kind of test they did, and blah, blah, blah. So that is something that is important. It sounds like you need to get to the bottom of this, but probably this is not the right forum for it. And I'd be happy if what you should do is to ask one of the geneticists who's perhaps directly or indirectly involved in your care already, or seek such a person out.
Maybe just to comment that renal Fanconi syndrome can be due to several other diseases and cystinosis. So cystinosis is a part of Fanconi, is the most frequent cause of renal Fanconi syndrome, but there are several other diseases which can be responsible. So if you have renal Fanconi syndrome, it's not necessarily that you have cystinosis.
Yeah.
Thank you. And we have a question from Zonka. Does it make sense to give Cystagon twice during the day and ProCysB at night? I don't think anyone wants to answer that from our doctors.
Well, I think there's some logic to that. If you're trying to sleep through the night, you can see the logic. The only problem is that it will be tricky to monitor trough levels, so I think it's one of these things where, although it's appealing, we don't know exactly how to guide you in dosing when it's mixed like that.
Thank you. We have a question for Rachel, if she is still here. And I know we had a lot of questions for the eyes. And the question from Laurie is, in corneal neurovascularization, what is the standard of treatment? Are injections of Avastin a good way to deal with it, or are there others?
Thank you. So there are others, and Avastin is a anti-neovascular medicine we use in many applications and can be used for new blood vessel growth in the cornea. Some people use eye drops, and there are other anti-inflammatory medicines that are used also during corneal graft rejection. It's hard to generalize an answer. The best guidance for someone who has corneal neovascularization is to be working with a cornea specialist. There are two processes. There's what is the active drive to cause the blood vessels to grow, and then what do you do with any scarring or changes that are a result of the blood vessel growing. The goal is to stop the active drive of the inflammation to suppress the underlying cause of blood vessel growth. So it's quite important to work with cornea specialists when managing corneal neovascularization. If it's very mild, the corneas can actually do okay. We call that panis. But if it's significant corneal neovascularization, it will usually need to be treated.
Thank you. We have some questions about COVID-19, and many of our community, especially with kidney transplants, are cocooning and isolating completely at the moment, and they are asking when that can end and where things are maybe with a vaccine. Anyone has anything they would like to share with us?
So maybe I have seen that Dr. Atif Evan joined the panel. Dr. Atif seeing a lot of patients in Dublin. So maybe Atif, can you comment on COVID-19, your experience and what you recommend to the patients? Atif, are you there?
I don't know if it's
I think he just left for a second.
Ah, okay.
Yeah.
Oh, Chief is not there.
So while we're waiting, I think the biggest problem I'm having in our pediatric kidney transplant program is patients, their parents are afraid to come to the hospital for important treatment. They're skipping blood tests, they're skipping infusions because they're afraid of getting COVID-19. And frankly, for children, they're quite protected, and immunosuppressed kidney transplant patients are even more protected. The only patient I have in my practice who has COVID-19 positive in the kidney transplant is asymptomatic, and it was picked up through routine screening. There's a beautiful article from Bergamo, Italy, where they looked at 700 liver transplant patients in their pediatric liver transplant program during their COVID-19 outbreak. Only 2 patients were symptomatic. So if you're a child and you're immunosuppressed, don't skip going to the hospital for routine medicines because you need that. And that's our biggest problem, is getting people to come for routine care.
Thank you.
I think it's very important to make a difference between pediatric and adult patients, because I think there are a lot of adult patients listening to us. As far as we know, the disease is very mild in pediatric patients. However, when you look at their experience from adult patients, they are also different, but in different series, their disease frequency and also the bad outcome is much more common in adult transplanted patients. So I would be careful when you're an adult transplanted patient having other problems such as diabetes, cardiovascular disease. I think in these patients, the disease can be really dangerous, and it's very important to be careful and not to come into contact with infected patients.
Thank you very much. So we are coming to the end of our conference, but I'm asking you, please don't leave for just a minute or two. I want to just say thank you to everybody, and we will do a very quick poll at the very end. But thank you to all our speakers. We just simply couldn't have done this without you. And you all came up and provided the speeches and your generosity, and we are very grateful. And we hope that you can take care of yourselves if some of you are looking after COVID patients in hospital. And we know that some of our cystinosis community, our parents and people with cystinosis as well, are essential workers, and we're thinking of them all at the moment. This conference was hosted by Cystinosis Ireland on behalf of the Cystinosis Network Europe, and we were very happy to be able to bring this to everybody online. We had, most of the time today, over 400 people online. And when you think that there were approximately maybe 2,000 people in the world with cystinosis, we're very pleased to have reached this many people. Our translators today have done a great job, and I realize now I'm speaking very fast here. So thank you to the translators. Thank you to our sponsors. and particularly Cystinosis Ireland and all my colleagues there in the Cystinosis Network Europe. Denise has done a huge job here in the last few weeks, and she has one more job left. We're going to do a quick poll, and let's see if we can get it up. So, how did you hear about the virtual cystinosis conference? My doctor or my child's doctor? Other healthcare professional? My own patient organization through Facebook? Other or a direct email from the organizers? For those of us in Europe, this really does feel like the Eurovision Song Contest voting system. So while we're waiting for that, you can still use the hashtag virtual cystinosis 2020. Send in photographs. I haven't seen any of them today myself, but I'll be looking at them later. So please continue to go there. 5 more seconds and the poll is closed, I think. And I think most people here today found out from their patient organization through Facebook. So from the patient organization, so that's thanks to Cystinosis Network Europe and all of the patient organizations around the world. We also had direct from the organizers, and we had from the Facebook page, and from the child's doctor, or other healthcare professionals. So thank you so much. And special thanks to Professor Elena Levchenko for being our scientific chair today. And she actually stayed on for the full 8 hours today to watch this. So do you want to say a final word, Elena?
Yeah, I think it ends me only to thank everybody, all speakers who joined us, who prepared wonderful talks. I would like to thank so many people who joined us today, and I would like especially to thank Cystinosis Ireland, you, Anne-Marie, Ruth, Denise, all people who worked very hard on this meeting, who allowed us to join together, which I think is so important for our community. We're a very close community. We like to meet, we like to hug, but I think this meeting was really impressive. It was heartwarming, and I had the impression during the whole meeting that we almost were able to touch each other, to hug each other, and to share our knowledge, our experience, our questions. I thank you very much for organizing this fantastic event. Thank you.
Thank you very much. And we have some other questions, and that we will maybe ask our speakers over the next couple of weeks if they wouldn't mind answering, and we will maybe post them. And I think that's it. We're just 4 minutes over the time, and our meeting is ended. I know the researchers and the clinicians, if they want, they have a private meeting now, and that's it, I think. So maybe Cystinosis Ireland, CNE, you could all wave. I'm going to put on my speaker view. There's Ruth. Bye, everyone. Joyce.
Bye. Thank you so much for everyone.
Bye.
Thank you so much.
Bye, everyone.
Bye-bye.
Bye-bye.
Everybody.
Who else do I see?
Take care. Stay safe.
Kira and Sinead. Will. Gail, all the way from South Africa. Hi, Gail. Nicole. Christy in the Bahamas, by the look of her, all the way in the United States. I see Freak, but he hasn't got his camera on. Thank you, everybody. Amy from the UK. Lily in Barcelona. These are all your CNE members. Karen in Dublin or Canada, wherever she is. Mano, Rory, Bert, Bye-bye, everybody. Bye-bye.
Bye-bye.
Mhm.